Hello there, and welcome to the April edition of the Healthcare Innovation Digital Health Virtual Series, the Telehealth Virtual Day. My name is Matt Rayner. I'm the publisher here at Healthcare Innovation, and we are so excited for today's program on all things telehealth. We have some fantastic sessions planned for you, our Healthcare Innovation audience. Please note that you can view these sessions along with us here today or watch at any point on demand over the next 30 days. Today's telehealth virtual day would not be possible without the support of three wonderful partners and friends of ours. So a big thank you to TimeDoc Health, Nuance, and Medallion for their support of this program. Now, before I introduce our opening session, a quick housekeeping note. This opening panel is designed to be interactive, and your questions for our panelists are welcomed. So to submit a question, simply utilize the chat functionality within the Zoom platform. We will do our very best to get to as many audience questions today that we can. Our opening panel discussion here, Telehealth New Directions, is being moderated by our editor-in-chief, Mark Hagelin. And at this time, I would love to welcome Mark onto this virtual stage to officially kick off our Telehealth Virtual Day and to kick off this opening panel. So Mark, take it away.
Thank you so much, Matt. Thank you to everyone in our audience for participating today. We appreciate it. And I want to say a hearty welcome to those in the future. I love welcoming people in the future who will be viewing this session later. I have a wonderful team of panelists here. What I'm going to do first is I am going to have each person introduce her or himself, their role and their organization. And then I'll make a brief level set statement about where we are with telehealth in the current strategic and operational landscape, and then we'll plunge in. So it's my honor to welcome Anna Schombaum, RN, Paul P.J. Helmuth, MD, and Tyler O'Coran. So I think I'll go in that order and have each person, again, just describe themselves, their role, and tell us a tiny bit about their organization so we know what kind of organization you're coming from. Anna, would you like to go ahead?
Yes, thank you, Mark, for having me today. It's a great pleasure to be here with this panel. I am Anna Schombaum, Vice President of Application and Digital Health at Penn Medicine, which is the University of Pennsylvania Health System. I am a nurse by trade, and in my role, I oversee a broad suite of applications and digital solutions, primary focus on strategic direction of the EHR system and just developing digital healthcare for the future. Penn Medicine is a 6-hospital health system, and we have over 40,000 employees in our health system. We are also an academic flagship institution where we do a lot of research and provide care in the ambulatory and inpatient space.
Wonderful. Thank you so much, Anna. Dr. Helmuth, I know you have asked us to address you as PJ. So PJ, please go ahead, tell us a little bit about yourself. And you actually have multiple roles.
I do. Yes, thank you. And again, I am happy to really be excited to be joining this panel today. I'm PJ Helmuth. I'm the medical director at TimeDoc Health. I'm a primary care physician by training. I still see patients in my office 1 day a week, so I can feel like a real doctor sometimes. I'm boarded in internal medicine and pediatrics, and I've been practicing for more than 25 years in Western Massachusetts, where I am. I do have leadership roles in our local physician hospital organization and ACO, as well as my role as the medical director at TimeDoc Health. TimeDoc is a virtual care management and remote monitoring software and services vendor. So we have patients across 35 different states. We have enrolled patients of about 60,000 at this time. And we do both chronic care management and remote patient monitoring services for those patients under our care management. And we, at my role there is as the medical director, sort of for both programmatic and to make sure the software and services align with the goals of the organizations we serve.
Wonderful. Thank you so much, PJ. Welcome.
Thank you.
And Tyler O'Corin, please share about yourself, Tyler.
Well, first of all, thank you for your time this morning, and I'm looking forward to the conversation. I am the director for telehealth and digital solutions with Centera Healthcare, and I specifically report up through our provider side of the house. So Centera, just so you have some context for who we are. Excuse me. We're a 12 hospital system, largely in Virginia, with a little bit of presence in North Carolina. We've got about 1,300 employed providers and almost 1 million member insurance plan. And so that's who we are, and that's the context I'm coming from.
Great. Thank you so much, Tyler. I really appreciate it. Sometimes I get a little bit confused between Centera with an S in Virginia and the Centera in Colorado with a C. It gets a little bit, so many health systems to remember. But yeah, no, we know you well. So thank you so much. I'm just going to welcome everyone. I'm just going to make a very, very brief level set statement. I think that this is a fascinating moment for telehealth. We all know what happened 2 years ago this spring. Really, it was 2 years ago, March, April, when this pandemic hit. As I like to say, it hit the earth like a meteor. It affected everyone on earth, which is rather an amazing thing. And specifically in US healthcare, of course, patient care organizations had to move as quickly as humanly possible to delivering as much care remotely as it was possible to do. And we all understand what the circumstances were. We understand how much of a crisis it was for everyone, including for providers. And since then, it's been interesting because that was a very high level of telehealth-based care delivery was sustained for a while. And then as things changed during the pandemic, the percentage of care being delivered telehealth wise started to decline somewhat, and it's kind of leveled off depending on the type of organization, somewhere around 25-30% of encounters. What I think is interesting is how various organizations have been trying to figure out what is the strategy for the future. Many healthcare consumers have come to realize more starkly during the pandemic that they have choice. Many really enjoyed telehealth and found it to be very useful. And of course, in our modern lives, people are incredibly busy. It's very difficult to take time out to see providers in person. Sometimes it's absolutely necessary, of course. There are times when a patient must be touched. But it's interesting that patient care organizations are trying to develop long-term telehealth strategies. And I think that's one of the things we want to talk about. What is this landscape like? So that's where we're at right now. And it's fascinating for me and my team to interview senior healthcare leaders at patient care organizations nationwide, because everyone is looking at this through a slightly different lens and trying to figure out what they do next. So I'm next going to turn to Anna, and I'll ask you, tell us about the comprehensive strategy that you and your colleagues are pursuing at Penn. I understand that it includes really thinking through telehealth across a broad context, from ambulatory care virtual visits to e-consults to ICU, e-ICU patient management, and even telesitter. So it sounds very exciting, Anna, if you could share with us.
Yes, at Penn Medicine, we were real fortunate prior to the pandemic that we had a solid foundation infrastructure in place, which enabled us to scale up successfully almost within weeks of the pandemic. And we were able to execute on a comprehensive strategy, and we continue to evolve. And as you mentioned, we have the ambulatory virtual visits, and our numbers have is remarkable. We started at 500 ambulatory visits per month. But then during the pandemic, we hit 8,000 visits per day, Mark. I mean, it's just amazing. So now we've settled out, as you mentioned, we're at anywhere about 1,500 to 2,000 visits per day now. But we have done over 1.5 million visits during the COVID period.
Yeah, if I may say, that's a pretty high percentage relatively, right?
Yeah, it really is. And we continue to utilize, because as you mentioned, our consumers are expecting to have some virtual visits. So we do 1,500 to 2,000, as I mentioned, virtual visit each day. We also, on the inpatient side, have leveraged our telehealth platform, and we have a eICU, virtual care ICU that's managed by our core group of practitioners. And we just rolled out Monday our last hospital with this eICU. So now we have this extra level of monitoring our critical care patients within the Penn Medicine health system. Also in the inpatient side, since we have that platform, we're able to do e-consults. So inpatient consults, if a provider needs a specialty consult, we're able to leverage our technology there. And then we are also leveraging this on the patient care side regarding telesitter. So we're looking toward to implement that. We have that enterprise-wide, but we're looking at leveraging more of a core strategy. And then one other teleplatform that we have is our urgent care model. And so this is a 24/7, what we call Penn Medicine on Demand, and it's for our staff and for some of our patients, where you can call if you have a health issue, and then right there within minutes, you'll be able to connect to a provider to get guidance and treatment. So that is just some of our telehealth, but we have it all through the spectrum. We do also have home health, a home health program where we do provide virtual care management visits as well. So it's through the whole spectrum of care.
Wonderful. And clearly you and your colleagues have kind of thought through what it is you want to do enterprise-wide.
Absolutely. We've been able to have a core foundation and have been able to expand on our programs.
Wonderful. Thank you. Tyler, I know you also have a broad enterprise-wide or organization-wide strategy at Sentara. Tell us a little bit about what you're doing and how you frame everything.
Yeah, thank you for the question. We, similar to Anna, had a experience where we were doing 30 to 50 visits a month, so not many, and we quickly ramped up to many thousands actually wasn't last, about 2 years ago, and so much so that almost 85% of our volume, outpatient volume, was virtual in those early days of COVID. And that was significant for us, and that really changed the tide for how we engage with patients, how we look at virtual and digital care solutions. Since then, we are really looking at telehealth and digital care in kind of two lights. One is a competitive opportunity, so one to stay competitively relevant, and then if we can offer a little bit better experience than some of our neighbors, and maybe even a competitive advantage. But we're looking at it from a perspective that there are a lot of companies and tens of billions of dollars being poured into startups from venture capital and private equity to take these low acuity patients from us. And if they can do a handful of our sinus infections, our UTIs, our birth control med refills, those types of things, then that's significant. That's a significant opportunity for some of these non-traditional healthcare companies. So we look at it as a defensive strategy with those partners or those entities, and sometimes even partners. And then we also look at it as an opportunity to better engage our existing consumers. And we are looking at it from that lens, and then the other would be access. So we can't hire enough behavioral health providers. We can't hire enough primary care providers. And we can't build enough practices. And at one point in time, that doesn't become financially viable either. And so we're looking at virtual health and digital health options to really help improve the access conundrum we're in. And ways to do that are to hire, partner with third-party provider networks. The issue that we run into there is integration and care coordination, but they do have the access. We're looking at hiring our own and developing our own core team of providers to develop just telehealth services. And really that improves the care coordination, that improves the integration. They can also do a higher level of clinical care. The issue there is it takes time. It takes time to hire them, develop those competencies, technology, those types of things. So those are the things that we're looking at. And then when it comes to price, and I think that's an important piece here. We don't know what Medicare is going to do.
Yeah.
Right? We got an extension basically through the end of this year. And if they give telehealth reimbursement a 15% haircut, as I've heard some say, then that's really going to hurt us. And so our strategies to I think react to that are looking at alternative business models. Like, can we just start delivering cash rate options at close to copay rates? And I wouldn't say we've figured it out yet. So if anyone has on here, please let me know. I'd love to talk with you. But that's one thing we're looking at. The other is decreasing our cost threshold. So that centralized telehealth team, they don't inherently need as much to deliver care. They don't need an office. They don't need all these other things. So we're looking at some lower cost options so we can still deliver this service to our patients. We can still deliver it in a high quality manner, despite the, maybe the lack of reimbursement we may see. And if we don't see that, then that is, I think, good for the industry all in. But that's how we're preparing for that as well.
Okay, wonderful. Thank you so much, Tyler. So let me just say two things. First of all, we will be talking in a few moments about the reimbursement landscape and about disruptors. But I'm so glad that you and your colleagues have already considered those elements and that you're thinking about the fact that your organization, like every patient care organization in the United States, you're not just competing potentially with the patient care organization down the street. It's much broader than that. It's becoming much broader than that. And those organizations that have at least begun to develop strategies are going to be ahead of those that have not. So kudos to you for that, I have to say. Now, PJ, tell us a little bit about how, first of all, how you see this in the context of developing value-based care delivery and contracting. And I do want to have you share a story about the patient in Connecticut with high blood pressure. We talked about this on our prep call, and it was just such an interesting tiny little anecdote / case study that speaks to how this all fits into planning patient care organizations really thinking about value-based care delivery and contracting. Begin wherever you'd like on that, PJ. Oh, you're muted, by the way. So
yeah, I'll begin by unmuting myself.
Right,
Sorry about
yes,
that.
please
Thank you, Mark.
Thank you.
So thanks. Yeah, I think that, we definitely see the lines of work that we're in, remote monitoring and chronic care management, in the overall landscape of virtual health, and that sort of movement toward value-based care with payment reform that keeps sort of chugging along, maybe slowly sometimes, but this idea that eventually we're going to be reimbursed for our outcomes and for the value that we deliver to patients, rather than just for the volume of care that we deliver. And we believe that part of that is going to be these ways to keep in touch with patients between visits. So as Anna and Tyler mentioned, before the pandemic, we weren't doing virtual care really. We weren't doing telehealth, and we didn't really have a lot of other virtual care, partly because we just weren't getting paid for it very well. And it's just It's hard to say you're going to stand up a big telehealth program or even a remote monitoring program until the reimbursement is really, it makes it financially feasible for an organization. I think that one of the things that we learned quickly is that when policy changes, we can change rapidly. And so, all of a sudden we're seeing a large number of visits. We're seeing these patients for their follow-up of hypertension, but we have no blood pressure data. We're seeing them for the follow-up of diabetes, but they haven't been to the lab to get their hemoglobin A1C because in the pandemic, they can't go and do that. And we don't have any home blood pressure readings. So we're trying to do chronic disease management without biometric data early in the pandemic and realizing that there is this gap here. And I think it brings up for us this idea, well, do we need to go back to the previous model of care, or do we think about how this is transformational for us? And so, certainly, to Tyler's point, our patients are going to find more convenient ways to access services because they do everything else more conveniently. They can order their groceries or schedule their dog grooming or see who's at the front door by looking at their smartphone. But when we call the doctor's office, we have to wait on hold and we leave a message and we don't know if we're going to hear something back. So I think that our sense is that we need to be part of that landscape where our patients are connected to us between visits. And that includes the ability for us to deliver the outcomes that we need for value-based care, whether we see the patient in the office or via telehealth, or whether we're connected to them through remote monitoring or some other means. With respect to value-based care, I think one of the things that we can think about is when we get closer to prospective payment models, maybe we worry less about whether we're getting paid for each of these interactions and more about what's the experience of the patient and what's the outcome that we're achieving. The example that I had brought up when I was on a prep call with Mark and Tyler was that I had a patient that I was seeing last Friday who had been monitoring her blood pressures with a home blood pressure monitoring in our remote monitoring program, and the blood pressures were running higher. She was scheduled for a telehealth visit with me for me to see her and talk about it and maybe titrate her medications. And she lives in Connecticut and my practice is in Massachusetts. And on April 15th, the ability for physicians licensed in Massachusetts to see patients who live in Connecticut expired. And so there had been an emergency authorization so we could do that. So I was now not allowed to do a telehealth visit with that patient. But in the context of value-based care, it makes sense for me to actually call her, titrate her medications. I did what would have been a telehealth visit. I looked at her labs. I looked at her blood pressure readings from RPM. I looked at her medications and asked her about adherence, and then I made a titration. I didn't get paid for that visit. So that's not an interaction that was reimbursed, but in the sense of value-based care, the patient got what she wanted. The quality score is going to improve because her blood pressure control is better. Her experience of care was better, but I didn't get paid for that interaction in a fee-for-service way. I do think eventually we need to get toward those models of care where we're looking at our virtual care landscape as how it's helping us to improve the outcomes as well as the experience of care for our patients.
Yeah, absolutely, PJ. And I'm just going to bring something up that was interesting. We had on one of our virtual panels last year when we went to all virtual events, Stacy Harantis, who is the CEO of Sharp Staley clinics in San Diego, California. And she made the point that during the first few months of the spring 2 years ago, when everything was shaken, not stirred in the healthcare system, they receive more than 3/4 of their reimbursement through capitated contracts. And so they did fine. Whereas everyone else who was primarily fee for service in other markets we all know, was really struggling. And one of the things that they have learned, having been involved now in capitated contracting, for 37 years is that once you make what you just mentioned, PJ, that kind of thing, just routine and the way that you deliver care, it changes the whole paradigm for the whole organization. So that's one of the ways in which telehealth can really eventually be part of this broad reconfiguring of care delivery, I think. But it depends on reimbursement, which leads to my next point, which is we're not sure what's going to happen when the public health emergency ends. Congress is going to have to reauthorize all the flexibilities that were given to CMS in March of 2020. The administration can't do it alone. Congress actually has to authorize it by an act of Congress. People are saying that there will be the votes to reauthorize payment parity and the licensure flexibilities and practice flexibilities. I certainly hope so. I hope that we don't go backwards if there's a change back in reimbursement. Does anyone have any thoughts about just what may or may not happen in that? Tyler, please go ahead.
Yeah, I have some thoughts and I have some hopes. My hope is that they extend all of the funding flexibilities that they initiated with COVID for another 2 years.
Yeah.
I heard a rumor that that was a consideration as well, and engage in some pretty in-depth studies to see the impact and if care, is either duplicated because of telehealth or reduced, or ED visit, volume goes down and things like that. And I think in that 2-year period of time, we'll see a dramatic change in both technology, in ease of use, in time it takes providers to engage in visits, to where if there was a decline in reimbursement, the technology would have advanced to such a degree and patients will become so familiar with it that hopefully it can offset and still be utilized in the practice setting. That'd be my hope. We'll see.
Yeah, that's definitely my hope too. Does anyone else have any thoughts? Otherwise, we'll go on. Anna.
I'll chime in. I hope that we do have some flexibility here. I do think we're just at the cusp of the whole digital technology and digital patient experience. So not all health systems are in the similar state, but as we execute our care delivery, I think it will take some time to do some measurements and some outcomes. And I agree with Tyler. If we can just push it out for 2 more years, I think you will reap the benefits and then have a more holistic value-based kind of program.
Yeah, wonderful. So let's now, I'm going to throw a bunch of terms out there and let's talk about them. Let's talk about the digital front door and how telehealth fits into digital front door strategies that are being developed, synchronous and asynchronous care management and communication, consumer empowerment. I have to say, it's interesting. I've been in healthcare publishing for 33 years. I wrote a cover story in 1991 about healthcare consumer empowerment having arrived. That was a little bit early. But now things really are changing. Let me frame it this way. One of the things we all learned during this terrible pandemic, we all got, speaking for myself, we all got addicted to going online, buying clothing and toys and home goods through Amazon or wherever and expecting really good service, right? Like you click a button and you're going to get your, tablecloth or whatever it is. And then it'll arrive and it'll be perfect. And if it's not perfect, you send it back. Sometimes they send you even a little container that you can create that you send it back in. And it's just like done like that digitally, right? And you don't have to like spend hours on the phone with people or go through call centers. You just get your stuff. And one of the things I think that has happened during this pandemic is consumers, and we're all consumers too of things, have gotten rather sharp-edged about service, right? And if you're not getting good service, you're pretty darn cranky about it. Now, healthcare, we all know, has not truly been consumer focused or consumer empowering until recently. I know you guys are all working on that feverishly in your own organizations. Now we're starting, patient care organizations are starting to develop digital front door strategies. They're trying to think about the empowered consumer. They're trying to think about different ways in which care teams can communicate with patients that are convenient for everybody and that work for everybody. How do you all see these concepts coming together? Do you feel the pressure to try to really be the first in your market, or at least among the first, to really be the shining city on the hill when it comes to making consumers feel good, making them feel that healthcare isn't just some kind of Soviet style bureaucracy that, take me somewhere with this. Who would like to begin?
I can begin. Go ahead, PJ, go ahead.
Sorry, we're unmuting at the same time. Thank you. I think that this is a really fascinating area that to your point, Mark, we are used to this convenience in every other aspect of our lives, and healthcare seems to be this one that is lagging behind. Yeah. And I'll give another example from my Fridays of seeing patients. I had a patient I saw on Friday afternoon, and he had a positive COVID test the evening before. He had called our office and left a message saying that he had a positive COVID test. He wanted to try to have an appointment to talk about antivirals. So I had him booked on my schedule at 2 p.m. So by the time I saw him and logged in, he had already done a telehealth visit with a CVS nurse practitioner and had gotten his Paxlovid already filled and taken his first dose. Because as soon as he hung up the phone, he didn't hear back from us right away. So he logged in and figured out how to get a telehealth visit with a nurse practitioner at CVS. And we did pretty well, I thought,
at least it wasn't weeks, right?
I mean, it was the same day, and we do have an opportunity where he could have booked his own visit online, which he didn't do, but again, he probably didn't know he could. I think, to me, that sort of is going to be, and Tyler made this point, this is going to be part of what we're competing against. It's hard for us to continue to take good care of patients when we have them receiving care at so many different places, some of whom have no interest or really incentive to share data with us. So it's really hard for me to sort of be able to take care of a patient who's receiving telehealth psychiatry and going to different places online for care if I'm not getting any data back to help with that experience. So I do think that this is a place where we just are going to have to do better if we're going to take care of our patients and compete. There may be times when we collaborate with some of these organizations who can do things that we just can't do. The digital front door, I think, is interesting because I'm always sort of conflicted about whether or not how much we need to build that versus just be able to communicate with patients about the aspects of care that they're interested in today. And I worry sometimes that we sort of spin our wheels a little bit trying to come up with the perfect digital front door when they find other ways in. But I'm curious about the other panelists' thoughts about it.
Well, and if I may comment, and then I want to hear what Anna and Tyler have to say. First of all, my sense in some of my recent reporting is digital front door is also kind of a banner that people are waving in organizations saying, let's just get our act together, right? Like it's a way to kind of summarize what what organizations have to do. So I think there's an element there, but also I think you're absolutely right, PJ. I mean, to me, the fascinating thing is historically, if you went back 20 years ago, you know, hospital system A saw as its competitors hospital systems B and C in their metro area, right? Now it's completely different, and it's becoming completely different. You know, people, this gets into a completely different area, but for example, corporations like Lowe's, I saw a presentation a few years ago at that World Healthcare Congress, where Lowe's, wherever you're working at a Lowe's, if you have a total joint replacement, they're sending you to Cleveland Clinic, right? And so now your local hospital in Montana is competing with Cleveland Clinic. That's really tough. So, and you have these disruptors, as we all know. You have CVS, Walgreens, and Walmart want to really get into this. I mean, pretty soon, everybody's sister-in-law is going to have a Minute Clinic, right? And the reality is that these disruptors aren't going to wait for established bricks and mortar healthcare systems to catch up. They're just going to do it. Also, we keep seeing surveys, and this, I think, you know, I have a certain amount of loyalty to my main health system that my physicians are affiliated with here in Chicago, but only a certain amount. And we keep seeing surveys of consumers showing that consumers really care about convenience, and they will drop their doctor and they will drop their doctor's hospital. So I think I hope that leaders of health systems realize it's not your grandfather's Chevrolet healthcare landscape anymore, right? So I just wanted to say that. And I know you have thoughts.
Yeah. Such good discussions. In a recent, or I guess it's not recent, it's 2019 Press-Ganey and Kaufman study, 96% of patients really wanted customer service. Customer service was their biggest complaint. So right along with you, we expect that now. Consumers expect convenience and control, and customer service is a big part of that. And then 75% of consumers also want their healthcare personalized. So how do you balance that? So one of the things that our health system's doing is we are looking at the digital experience of the whole touch point of the consumer at every touch point. So it may be that it is by trying to search for a provider on the internet, all the way to call center, contact centers, and trying to get in just to make that access. And you're right, Mark. It's, you know, just we're trying to get coordinated and to help with that communication and fine tune our processes as we look to this. And we're using technology as a vehicle to make that experience better. And so we're looking at it from a pre-engagement. How do you find the providers and how do you find that experience? Then when the patient is with us, is to make sure that we do personalize that journey and that treatment, and make sure we connect that and build that trusting relationship with the patient and make sure that they have a positive encounter. But then once they leave us too, is to make sure that we have also a post-visit experience that is also just a follow-up, whether it's by a virtual care management visit, or maybe it's just a touch point and saying, you know, we were glad to serve you. But it's kind of the whole spectrum.
Exactly. Thank you, Anna. Tyler, I know you have a few thoughts.
I do, and I appreciate the previous comments. One of my favorite things I've heard recently is we deliver a service no one wants to use. So we're not like Nike or Amazon, because those are services and products people want to use. They don't want to use hospital services or healthcare services unless something is wrong. And so I to touch on what Anna was saying, we're really looking at how can we make this experience that you don't want to have less painful and maybe even enjoyable.
Yeah.
And I think that comes from looking at analytics. When I think most health systems look at analytics from operational perspectives, how many visits did we have? Anna and I have both spouted out number of visits we did in a year, and operational, and are we efficient, are we effective, employee engagement, those type of things. I don't think we do a good job as a industry at looking at what do consumers want and how did they rank it. We do Press Ganey or other type of surveys, but those are, I think, just touching the surface. I know from friends that work in other industries, they can tell you what type of car the type of person drives that typically buys their product, what their age is, how many kids they got, if they got any kids, and we don't have that level of sophistication generally here. And I think we could do a better job of understanding our consumers and then delivering on the type of services they want, whether it's how they receive notifications. What do those notifications have in them? What is that after visit experience like? We usually print out an after visit summary that everyone gets, same template, just different content. Well, I don't like that, but I know my mom does. I want something that I can click in and dive into really deep and go into some really deep things online, but I resort to Google for that. So I think there's a lot that we could do to make the experience better based on what different types of our consumers want.
Yeah, I completely agree. First of all, I completely agree with what all three of you have said. I just want to share two brief personal stories. Don't worry, I won't be too TMI, but that to me illustrate what consumers want in healthcare and don't want. The first one is I and others through my health system supposedly have a PHR that's related to one big EHR that everybody knows about, but the health system doesn't really do anything with it. Like it's essentially a blank, like you go in there and there's nothing there. So that's dissatisfying. I mean, this is one of the reasons why the PHR has been so problematic. No one wants to maintain it or update it. That's a small story. The other one is recently I went to see my PCP for an issue, and he said, well, I want to take a bunch of tests. So they took 2 vials of blood from me. I never heard back about the results of the tests. I called twice. His office is only 4 blocks from me. So on a walk, I actually stopped by. I went up to the 7th floor where his offices are, where the practice is. It's a salaried practice, a part of the same integrated health system. And I actually asked the front desk person to ask him for the results. And she said, I'll write a note and I'll put it on his desk right away. That was 7 weeks ago. So, this is like I just wanted to know what my test results were. Now, if we had a really functioning PHR, I could just look them up. Or if it were in some other way online, I could look it up. Or if I could do asynchronous messaging, and it wouldn't have to be with him, it could be with one of his staff. I don't necessarily need to speak to my doctor directly. I just want my results. So that was dissatisfying, right? Like this is so, and I know how the healthcare system works because I write about it, but to me, this is like a really basic thing, right? If we should be able to give patients access to their lab tests, and it shouldn't have to take several months or another in-person visit. So anyway, I just think that in some ways, patient care organizations really are starting from behind the 8 ball because certain things are extremely inconvenient still. So I just had to say that. Let's talk now about clinicians for a few minutes. What is it that clinicians need to know, think, hear, feel, do, experience with regard to how they are obviously physicians and also nurses are very much a part of this telehealth experience. How do we communicate with them and how do we make them feel that this is going to work for them and will meet also their needs as practicing clinicians? PJ, could you just say a few words?
Sure. I think it's first of all, I'm sorry for your experience with your doctor. That is not ideal. And I do think that it sort of brings up some points that both Anna and Tyler made about how we need to do a better job of personalizing the experience for patients. And I think that also, comes to this question of clinician experience. I think most doctors have had that experience of having a patient come in and say, don't you know what my cardiologist ordered, and I don't because they didn't send me a message, or they sent me a letter that got put and it's in a PDF in form in some place in the chart that I can't find. Patients keep being asked the same questions over and over by different members of our care team, and then we don't find it in a way so that we can sort of present it back to the patient. So we've got lots of data in these EHRs and PHRs, but they're not being aggregated and analyzed, and the insights aren't coming forward to allow the clinicians to take advantage of them. I have a patient who's on remote monitoring, for example, and all of these, millions of data points are coming into the EHR. Somebody has to find a way to pull out the insights and then personalize that back to the patient so that they understand the experience. But it makes it easier for the clinician to also not only consume the data, but communicate with the patient. And I think we have we're missing that step. We've got lots of data. It's sitting in places that we can't easily access, and we're not getting the analytics and insights from those data to allow us to interact with our patients in a way that's satisfying for them.
Exactly. And it's not coming to the clinicians in a convenient way for them either.
Right. And I think the clinician experience is people like me keep coming to them and saying, do better, do more. You need more data from this. You need remote monitoring. We need to do this. We need to do that. And they're saying, how am I going to manage all of this incoming information and still maintain these relationships? Patients, to Anna's point, patients want to trust us, right? And part of how they trust us is that they think we know them, and we're having a hard time finding out how to consume all of the data coming in a way that communicates to the patients that we know them and that they can trust us with their care.
Yeah, absolutely. Anna and Tyler, do you have any thoughts?
I think regarding technology or workflows for the clinician, it's really important to get their feedback and to design a workflow that works for them, that's simple. We've inundated with too much information, as PJ mentioned, too much data, but what is the visualization of what they really need to know in order to take care of that patient? And so there may be some technology regarding artificial intelligence or robotics or machine learning that maybe aggregate and provide some data to the clinician for that visit. But I think sometimes we over design, and but if we keep it simple, harmonize, integrate, and to be able to share data from one setting to another or health system to another, is to make sure that it's interoperable in the sharing of that data. But it's also to it's new technology, everybody adapts in a different way, and to have different training modules and to have that elbow support for those clinicians. Some people adapt it real easily, as well as patients. One of the things that we are doing is before a patient goes home is to also show them how to do virtual visits and how to use their patient portal, because the patient portal is their link to their data and their information. So we just want to make sure they get comfortable with that if it's a new technology for them.
Yeah, absolutely. Tyler, do you have any thoughts before we go on to the next thing?
I just want to second everything that PJ and Anna said. I couldn't agree more.
Okay, great. So what does this whole landscape look like over the next couple of years? And then we have a question from the audience. But first, I just wanted to ask you to look into your crystal balls. I'm sure you have them.
Yeah, I'll go first on that. Here's what I think is going to happen. Here's what I think and kind of hope is going to happen. I hope that the number of virtual care vendors out there, third-party partners, offering everything from primary care telehealth services to behavioral health to RPM, whatever it be, I think there's going to be some consolidation. And then my hope is that they open up their technology stacks in such a way that we can integrate them better into our EMRs. And I know there's the two big ones in the country, Epic and Cerner. They are becoming a little bit more open-minded about how they approach that, and they're allowing more things to happen, both of them. And I hope that these non-traditional healthcare companies start to integrate better. And that way that then the incumbents like Centera or Penn or whoever, we can have better care coordination. So when they see a telehealth provider from a third party, we have that as an encounter within our EMR system, and we can follow up maybe even with that provider and make sure that we're not missing things. We're not double prescribing antibiotics, or we're not doing whatever else can happen there. The next thing that I'm hoping for, aside from the reimbursement we talked about earlier, would be an overall clarification on the rules for Medicaid and state licensures. And I'm hoping that the states will come together and calm down and realize that if you're good to practice medicine in Colorado, you're probably good enough to practice medicine in Virginia and probably good enough to practice in California. And I wish we could get to that state. And then the final, so I'm hoping that'll happen in the future. And then the final thing is, I think we're going to see a dramatic focus on the provider as the customer. What I'm finding is 96% of our telehealth visits are driven by the providers, not patients. It's providers saying, hey, Ty, let's make that a video visit. Or the office staff or the call center staff saying that. And so I think we're going to see a dramatic focus and change in the actual technology our providers engage with patients, so that it's easier for them, it's simpler, it's faster. And I think said we overcomplicate it. We over-engineer things way too often. But I think everything's going to get better from their perspective, so they're not having to play IT support or any of those types of friction points. I think will start to be dissolved. So that's kind of where I'm hoping, where I think things are going to go to very high level.
Great. Thank you so much. You know what? I want to respect our audience and answer their questions. We have 2 audience questions. I'll throw them out and we'll have about 3 minutes for each. So the first question is, I would be interested in staffing models / standards for virtual care centers, if anyone could speak to that as we look towards long-term telehealth. Anyone want to briefly talk about staffing models or standards?
I'd be happy to share with Jennifer offline if she types in her email address and share our model. But just high level is that we have a central model staffed with APPs that do the EICU virtual of 6 hospitals. It's 24/7, and we add that layer of surveillance to our patients. But happy to connect with the director of our center to have that discussion.
Yeah, that would be great. Jennifer, if you would be willing to put your email in the chat, Anna will respond. That's wonderful. Thank you so much. There we go. Thank you, Jennifer.
I too am happy to do that as well.
Oh yeah, great.
We have a few different models. We've centralized both EICU, primary care light. We're developing a primary care urgent care model as well. So we're developing a few different models. But yeah, happy to share with you what we've done and what we're doing.
Great. Wonderful. Wonderful. Thank you. And one more question. What are your thoughts on equity and how it relates to telehealth, where some patients may not have access to the technology, e.g. broadband devices, et cetera, to take advantage of this option? Oh, we could have a whole panel on that. But briefly, if one panelist wants to leap in and kind of speak to that, I think it's very, very important. Who would like to raise their hand?
I'll take a stab at it from our point of view as a vendor that provides devices for remote monitoring. One of the things that we've really tried to work on is making sure that we are really just using devices that are cell enabled, so that patients don't have to have other technology in their home in order to use them. We know that sometimes it's a matter of them not having access either to broadband or to a smartphone or a Bluetooth device. And so if we just give them a blood pressure monitor, glucometer, or a scale that is cell enabled, they just open the box and use it, and the data come across to our platform. We see that as important for both convenience, but also as a health equity point. We're not sort of saying, oh, well, if your patients don't have a smartphone, they can't use this. I think this is going to be, trickier as we sort of think about, can patients text with us? Can they do video visits with us? That makes it a little bit harder to scale to people with technology barriers. But at least with respect to devices, there are some solutions which we're excited about.
Wonderful. We literally just have a few minutes. So what I think I'd like to do is I'm going to go around the virtual table here and just ask each panelist to leave us with a piece of wisdom. It can be an advice for our audience, an observation, just something that you'd like to conclude with that you think our audience should know based on everything that we've discussed in this past hour. I'll go in opposite of order. Well, I'll just go around the clock. Tyler, would you like to go first?
Here's my thought. Because we don't know what the future is, my ask and my I guess recommendation is to please reach out to me and we can talk it through. And maybe collectively we can come up with a better answer than individually. So I'm happy to talk to anybody. If you need, just reach out. And would love to carry on the conversation, work through common problems that we all are probably asking and working through. I'll put my email in the chat.
Wonderful. Thank you, Tyler. PJ, would you like to share just a word of wisdom?
That's it feels like such a terrible setup, word of wisdom. So I think, my hope and I hope it's where we're looking to go is that as we continue on the path of payment reform, we do get to a point where we are finding ways to use digital technologies for a virtual care experience that gives people the care that they need conveniently, that focuses more on patient outcomes and patient experience, using the data we have to really look at patient experience and patient outcomes, and we can move past to some extent these sort of annoying questions of, do we get paid for an asynchronous visit? What's the cost for a telehealth visit? Like, if we're just giving the right care and we're getting paid for the outcomes and the experience, that makes us, I think, opens up our ability to innovate in ways that makes things better for patients and providers and the health system.
Absolutely. Anna.
One thing I would hope for that we can achieve is to look at all patients in all settings and make sure that we're looking to improve care with whatever modality and to achieve health equity. And always keep that in mind as we bring new models into our workplace or new technology, and to make sure we can serve a diverse population.
Absolutely. Thank you so much. I'll just say this. I think that everything that we've talked about and that everything that's going on in this area speaks to where US healthcare is right now, right? We've got all these complexities. We've got reimbursement and policy and operational and IT and process complexities. It's just this gigantic ball of wax. I think what you said, PJ, is exactly right. Well, everything you all said, but if we can just get paid to do the right things and achieve the right outcomes, that would be great. The thing that many people have said, this is far from original, far from original from my mouth, but the way that our payment system was set up in this country was so complicated and convoluted, and frankly is problematic now. Because the fee-for-service system has been a sick pay system. It's paid for providers to and incentive providers to wait until someone is sick, really very sick, and then you're working at a very high level of acuity relative to where the incentives should be, right? Or as I like to say, tumors the size of baseballs. So if we can get the healthcare system to really do all of these great things, and telehealth is a part of those great things, to really meet patients where they are, kind of literally to meet patients where they are, as far upstream. I think I said upstream before when I meant downstream. We need to meet patients upstream, take care of their chronic illness, because chronic illness is the biggest burden on our entire health system. that will be moving in the right direction. You know, the Medicare actuaries came out again and said, you know, we're headed toward nearly 7 trillion a year in US healthcare expenditures. We're at, I mean, isn't that insane? We're at 3.6 trillion-ish right now. And we're basically going to be doubling our costs, and part of it is the aging of the population and the explosion in chronic illness, but basically doubling the cost of the healthcare system in the next 5 to 6 years. How wild is that? Like, it should really be mind-blowing for everyone. So everything that you guys are doing is wonderful because it's moving us, we're rowing in the right direction. And I hope that we will row faster. So I want, we are literally out of time. I want to thank you all, PJ Helmuth, Anna Schombaum, Tyler O'Corin. You've been wonderful. We appreciate you tremendously, and I think this has been a great discussion. And our publisher, Matt Rayner, has magically reappeared to help conclude this session. So I'm going to thank you all. Thank you.
Yeah. Thank you, Mark. And I'll also echo that. Thank you, panelists. A great way to kick off our telehealth virtual day. Our next session, which is a discussion around the role of AI-powered technology in optimizing telehealth, is available to watch right now on the Telehealth Virtual Day website portal. So go ahead and check that out. Within that portal, you're also going to find some wonderful content assets from our friends at Medallion that you can read, and I encourage you to do that as well. With that said, I'd like to thank you all for watching this opening panel discussion, and we hope you enjoy the rest of the Telehealth Virtual Day program and content. Thank you and take care.